So let me introduce Dr. Phani Krishna Ravulla. He is again an SGPGI alumnus. He is now a consultant HPB and transplant surgeon at Pace Hospital in Hyderabad. So Phani, please come in. And Avinash, you wanted to ask something, so please come in and ask. Avinash is again SGPGI alumnus, GI consultant surgeon at Ahmedabad, and he and his team offers all the technical support for all our online educational activities. Yes, Avinash.
Good evening, sir. So my question was, most of the question has been replied. You put a questions to Dr. Raj, and that question I noted down. So sequentially put all the question to him, and he is very nicely replied. So far I don't have any queries, sir.
No, but you should read out those questions and answers for everyone's benefit.
Okay. Yes, sir. Yes. So the question you asked to Dr. Raj Prasad was, is there any cystic lesion on a sonography? What we should do? So his question was a cystic lesion. He will like to get the history of the previous investigation. Any investigation from the ultrasound done in the previous year, and that is showing the similar lesion, he would like to wait for a time. And if the patient coming with the first time with the reports, and reports showing that multiple cysts in that, then he would like to do the cross-sectional imaging. And even then, that's with a simple wall-like cystic, then he would like to wait. Now, sir, Phani has joined.
Yeah. Is there any other aspect which we want to discuss, which we want to cover? I would go back again to and take Phani's opinion also on this a complicated cystic lesion, which is looking like hydatid, but it's not typically hydatid. And we all have had this experience that we treated as hydatid and it turned out to be biliary cyst adenoma. And Raj mentioned that because they have a more aggressive approach, they have done resection and it turned out to be just a simple cyst. So are there any tips on imaging to differentiate between these two, Phani?
The first thing, the location is one area, sir. If it's a peripheral lesion in the periphery of the liver, not impinging on the hilum, you don't really need to break your head. Like, is it a cystadenoma or a hydatid? Because it can be safely resected with very less morbidity. So even in a hydatid, we know that if it's a peripheral lesion, resecting, you have less bile leaks, less recurrence rates. If it's a central lesion...
So you are saying that if it is a peripheral lesion, even if it is looking like hydatid,
dilemma
for a cystopericystectomy.
A resection, non-anatomical resection. So on the other hand, if it's a central lesion, obviously it would impinging on the hilum and it entails a major hepatectomy, then this dilemma is there. One thing is the pre-op, the hydrated serology and asking the ultrasoundologist to look for the membranes and hydrated sand, that is helpful. But in the most complex of cysts, the intra-op findings of hydatid also, once you have a look at the cyst visually, it's totally pre-op on the imaging, you may not be able to differentiate, but on table, once you just do a cystotomy, you can easily identify a hydatid from the membranes and the daughter-cysts. So the on table, it's very easy to differentiate. There's not much of dilemma between biliary cystanoma and hydatid. So for the central lesions, I would suggest we can do on table, we can make the decision. Maybe anyone else has.
It could be possible only if it is on the surface. Suppose it is all covered with normal liver parenchyma. It's a pure intraparenchymal lesion, which is looking like a complicated cyst. Would you do an intraoperative needle aspiration? Are there any, other than microbiological examination looking for hydrated sand, is there any typical biochemical or cytological, maybe Arundhati can come in, feature which can say that it is a biliary cystadenoma? Arundhati, any cytological features in the fluid which we aspirate from a biliary cystadenoma? Can it help?
We've never done that, but I think you can do a microscopy for scoliosis, sir. But in the type 4 and type 5, if there's really a diagnostic dilemma in this, I would err on the side of go ahead and resecting it, because even a hydatid cyst, if it's like you're saying, not peripheral, very centrally located, treating it by a simple partial cystoperitoneum is very difficult, with a high complication rate of major bile leaks when it's very central and impinging on the hilum. So other than the serology and the looking for scoliosis, the approach would be, I feel, more of on the side of more resecting when there's such a dilemma.
The other is that if we see a solid SOL in the liver and the AFP is normal, PIVCA also is normal, the radiology is not suggestive of HCC, and then you start thinking whether it is a solitary metastasis with an unknown primary. So before you go for endoscopy and PET scan, as Raj suggested, would you first needle this lesion, confirm that it is a metastasis, and then do those, or would you, based on radiology, only think that this is a metastasis?
No, definitely in a non-cirrhotic setting, if the solid liver SOL and with an unknown primary, we would definitely do a biopsy, sir, because it'll totally change your workup. Let's say if the biopsy comes as a neuroendocrine on IHC, then the imaging you do would be totally different, and where you might not do a pan endoscopy and do a Dorotac PET scan first. So a biopsy is mandatory, and if it's in hepatic cholangiocarcinoma and such.
Suppose you can't locate the primary. We've had one such case. What would you do? Would you go and resect this metastasis, or would you follow it up?
So actually, I wanted to ask this question to Dr. Prasad sir also. We've had this situation a couple of times. It's not just you can't locate a primary. You on your IHC, it's so poorly differentiated that the IHC doesn't give any clue. Obviously, when you can't locate a primary, you expect the IHC to give either some unknown primary in the breast, lung, or any such thing. It's such a poorly differentiated that the IHC has not given us any additional information. Obviously, in such a case, you would have to no other choice than, if it's amenable to surgical resection safely with less morbidity, we have offered surgical resection, and actually these patients have done very poorly. So I even like Dr. Raj Prasad or Dr. Bala to give their opinion on this.
Raj, what would you do?
So sorry, Phani, can you remind me the context?
Yeah, so single solid SOL in a non-cirrhotic liver, and it's a metastasis, but we can't type it. And we've done pan endoscopy, we've done PET CT, but we are not able to locate the primary. So what would you do? Would you resect it, or would you keep it under follow-up?
So it's an adenocarcinoma. So it's an adenocarcinoma, Phani, and all the upper biliary immunohistochemistry is negative. And is that the situation?
Not actually. I think what I was referring to is a situation where it's not even an adenocarcinoma. So it's a poorly differentiated lesion, and IHC has given you no clue as to a primary, or is it any clue of the histological origin. So in that case, if it's resectable, what would you do is what Dr.
Yeah, I wouldn't just go and resect poorly differentiated cancer as the first or without some time, and so you done PET CT also?
Yes. PET CT,
and it's all localized.
Endoscopy doesn't give any clue as to the primary in that kind of a situations.
Yeah, maybe arm twist the medical oncologist to give some systemic therapy, and then buy yourself 3 months time and let the tumor declare. I think that would be my approach.
How do you decide which chemotherapy?
Yeah, it's not my headache, no. It's just all you have to do is convince the medical oncologist to see them. I'm sure they wouldn't hesitate starting something or other.
So you would wait, but suppose after 3 months also there's no progression or something, then you would
give the patient the pros and cons, and if they accept that, we have a phrase, nothing guaranteed. That's what we tell them. You can't guarantee anything. The only thing is we'll get them through the post-op course with that whatever mortality risk is, and after that, just unknown. What do you find is, I think most patients by that time would have established some link with their medical oncologist, and they take their advice too.
Dr. Saraswat, anything else which we haven't covered for liver SOL you would like to add?
No, not really. I think it's been a very comprehensive discussion, as well as presentations have been very nice. I think what I'd like to bring to the attention of the audience as well as the panel here, I think I don't know how many of you have had a look at the recent nasal BCLC classification. The Indian National Association for the Study of the Liver, in their recent update on HCC guidelines, have tried to modify the existing BCLC classification, which is by and large used by most people working on HCC, in terms of breaking up BCLC-B into B1, B2, B3, and C1, C2, and D1, D2, and trying to also offer tailored interventions and therapies in these people, because the BCLC hasn't really talked about SBRT at all. Even TARE doesn't find prominent mention in the BCLC algorithm, which has been incorporated. So, since as many as of you would like to take a look at that and see if you can try and implement or work on it in your practice and see how it suits you in your decision making, particularly in the BC decision therapies. And the other thing is that I think increasingly people are looking, especially with the advanced disease, maybe BCLC-B beyond transplant or BCLC-C, are looking at combination therapies, loco-regional along with systemic therapies in this situation. And whether that can actually downsize and the complete or the partial responders to immunotherapy can come from beyond UCSF well into in the Milan range, and whether they should be offered transplant at that point remains unexplored or not supported by too much evidence, but yes, case reports coming in now. So those are something that would be of interest.
So before I ask Bala to make some concluding remarks, Biju, TD, Dr. Arundhati, you want to add anything? Otherwise, I will request Bala to maybe give some take-home messages. Yes, Bala.
Yeah, I think we still have 15 minutes.
It's okay. We can always close before time. We never exceed 9, but we can always close before 9.
So I think I should go back to some of the old questions which have been raised throughout the day.
Yes, yes.
Start from backwards. From what Phani kept on telling is, I'm going to resect a cyst, which I feel a little difficult to understand, because if there is a cyst, actually why I'm saying this is most of our liver surgeries, I would say more than 90% of our liver surgeries these days we do laparoscopically. So if there is a cyst, is it not very simple to just go in, do a nice cyst wall excision, whatever you can, send it for biopsy, wait for the report. It will take hardly 15-20 minutes. If that says biliary cystadenoma, in that case, you can go ahead and resect. Otherwise, is it not enough to just lay it open? Phani, you need to answer this.
Yeah. So we were referring to a context in which there is a complex cyst, which already has, when there's a complex cyst with septae and there's confusion between hydatid and biliary cystadenoma. It's not a simple cyst, obviously. In that context, I was saying that especially when it's in the periphery, I would not really, I would be more towards resection rather than trying to do a biopsy and figure it out, or continuously evaluate pre-op any further aspirations and all that. So in that context, definitely if it's a simple cyst, I mean, there's a very high likelihood of a simple cyst and the suspicion of a cystadenoma is very low. In that case, we can do we can deroof the cyst, do the biopsy, send it for frozen. If not, the biliary cystadenoma, sometimes on frozen, if there's suspicion of malignancy, they may not be able to give a complete report in the frozen. We can go back in also in such a rare situation. But if it's a complex cyst in which there's suspicion of biliary cystadenoma or a complex hydatid, especially if it's in the periphery, I would rather resect, because the mobility, even laparoscopically, I mean, a non-anatomical resection for a peripheral cyst is very less. So rather than dilly-dally with a lot of investigations.
I think it's just a difference of philosophy, because what Bala is saying is right, that if it is truly a biliary cystadenoma, a biopsy in the first go and a resection in the second go is not going to change the outcome, the long-term outcome of the patient, unlike a malignant lesion. But Arundhati, if you are still there, suppose we send you cyst wall. Will it be possible for you to tell us all the three conditions, simple cyst, hydatid, and biliary cystadenoma? Frozen? Not frozen.
You can send quite a big amount of wall.
Yes, yes. I think she's probably. Oh, yes, yes, Raj, please feel free to. I know it's very early morning for you. Thank you very much. Thank you for joining. Thank you.
Thank you. Good to see you. Thank you.
I suppose, I don't know, does anybody know whether a pathologist can diagnose biliary cyst adenoma on frozen? I'm not sure. Because I'm again and again asking this question because back there in SGPGI twice, I have burnt my fingers that, I mean, in our team, that we treated it as hydrated, but it turned out to be a biliary cyst adenoma, and then we had to go in again.
Sir, I think, can I say?
Yes, yes, please.
This is one is radiology, then that is MR. After CT scan, if there is confusion, MRI, very classical picture. Then you combine it with the this antigen based hydrated serology, and if it is negative, and our MR findings are going in favor of cyst adenoma, then I think there will be very rarely will find a patient where it will, after resection, you will find that it is really hydrated. So this is what we have resected, and hardly we have found any problem. The problem is, if at all, like Phani is saying, rather than opening, you aspirate also. And in a hydrated, definitely you are going to get something on aspiration, which will not find on biliary cyst adenoma by any chance. So if we take clinical scenario with the age and all, with the, as you said, younger females, and then classical picture having no the increased level of the this hydrated serology, and on the top of that we are having a picture which is very close to the cyst adenoma, rather than thinking, then probably it will be very rare to have a differential diagnosis problem. This is what is because nowadays radiologist friends are so good in going and seeing about MR, and they have different pictures so nicely. But one has to go and sit with them rather than seeing the film, and probably I don't think there will be many patients where we will have a differential diagnosis problem of hydrated and cyst adenoma.
From what you people are saying, I am getting to understand that you are still using hydrated serology as a routine.
As a routine, we use, sir, as a routine, because the hydrated serology, obviously, we use in every patient. We are not doing that, but yeah.
If the hydrated serology is negative, do you not give albendazole to these patients before you operate upon them?
Sir, usually, then we go, as I said, we have to combine everything.
No. So radiological picture is suggestive of either hydrated or biliary cyst adenoma. Hydrated serology is negative. Would you straight away operate upon this patient or still give albendazole?
I go for immediately for MR. If we have only CT scan, we will go for MRI and discuss with the radiologist. Yeah.
Agreed.
After that, no albendazole. If everything is fitting into this, no albendazole.
So a small comment about what Dr. TD told.
Yes.
There is no algorithm should go without MR in suspicious cystic lesions in the liver. That is very clear. All this confusion we should discuss only after doing a high quality MR. Because what we are actually looking at is the walls and mural nodules, and what is the character of the septum of that lesion. This is what exactly looking for. CT will not give you that much accuracy. This is what I wanted to.
For the students, I would enlarge that statement and say that for any cystic lesion anywhere, MR is usually better investigation than a CT scan for evaluation of any. Same holds true for cystic neoplasms of the pancreas also. Anything else, Bala? Any other?
Yeah, now since TD Yadav had raised the last question. So regarding portal pressure, actually what we do now is a very simple thing. It's a US guided portal pressure measurement. It's actually pretty simple and barely takes a couple of minutes. And we have found that US guided portal pressure is equal to what we measure on table. So any patient with HCC before resection, we actually get the US portal pressure done. If the portal pressure is between 8 and 10, that is a gray zone. Above 10, we tell them transplant straight away. Below 8, you can go ahead with massive resections or any resection you want. Between 8 and 10, you have to think of altering your management. And coming to portal vein embolization, we have been doing that, but for these years, hardly had any patient where we could actually gain from portal vein embolization. It's much more simpler to actually tell them transplant. So,
can you please elaborate on the technique of this US guided portal pressure measurement for the sake of the audience?
It's done by the gastroenterologist, and US is pretty common here. So they just visualize the portal vein and directly puncture it. And with the same way we measure actually on-table portal pressure measurement, the same monitor, the same pressure measuring apparatus. It's pretty simple actually.
So transgastric, transduodenal?
Transduodenal.
That's right. I think people have been using that, but I don't think it is very commonly practiced. It has been reported, it has been demonstrated in a few conferences, but you guys seem to be doing it routinely. Almost everyone has the concern is of complications because you're directly puncturing and withdrawing without doing anything else, whether there'll be bleeding, particularly if there is any suspicion of pre-existing chronic liver disease, coagulopathy is present. So I'm not sure it is a widely practiced thing, and is it nowhere close to replacing HVPG for measuring the portal pressure or gauging the portal pressure?
Yeah, we did for our last 30 transplants actually, and they were all cirrhotics. Most of them were actually pretty sick patients. I think few of them had minimal hematomas, but otherwise we did not face any problem.
Yeah, but I think I would add that it needs a lot of experience and expertise, and it has to be done very, very guided and carefully.
The other way around is getting an HVPG done for all HCCs, which we used to initially practice.
Okay, so I think I will take this opportunity to thank all the panelists and the moderators. Yesterday we had Dr. Namish Mehta and Dr. Saraswat. Today, Dr. Phani Bala and Dr. Saraswat. And thanks to Avinash and his team for providing continued support to all our online academic activities. Thank you, everyone. Thank you very much. We will soon announce the theme and topic of the next month's masterclass, and all of you are most welcome to join and contribute also. Thank you.
Thank you, sir.
Thanks, sir. Thank you.
Very nice afternoon, evening.
We will close. Yeah.
Okay.